So, hello everyone. We are hoping that you are in a very good health, in a very good. You are enjoying your day today, and we are very grateful for having this webinar. We are having the third webinar in our webinars for the Middle East, and we are having a very exceptional speaker, Dr. Hasan Abu-Maizar. He is a very exceptional speaker and a consultant in endodontics, and we are really grateful that he accepted our invitation. And sorry, doctor, for any delay happened today. Extremely sorry.
Not at all, that's fine.
So, thank you so much. So we'll be having Tasneem, the regional ambassador of Middle East of IADS. She will be moderating the session today. So the floor is yours, Tasneem.
Hello, everyone. Thank you, Mary, and thank you, Tasneem, and thanks for the International Association for Dental Students, IADS, for inviting me to give this a few tips in endodontics. And of course, thank you for the local JADS, the Jordan Association for Dental Students, for making this happen. First of all, I believe that most of you are students or fresh graduates who have joined us today for this presentation. I hope that you are enjoying your holidays. I believe that most of you now are have a summer vacation, aren't you, everyone? Okay, that's great. So basically, we will talk this presentation, a few tips in endodontics, mainly in 5 subjects: glide path and patency, working length, confluent canal, finding calcified and missed canal, especially the MB2, and a couple of additional tips as well. First of all, we're going to talk about the glide path. All right, glide path, I'm sure that most of you are familiar with the definition of it. Basically, is to secure the canal from the beginning of the orifice, all right, in the pulp chamber, up, down, or up until you reach the apex of the tooth. When we have a smooth, reproducible glide path, as in at every coaster, roller coaster, sliding track, water slide, they all have one common thing, is that they have a reproducible glide path. And we need to achieve that in endodontics, able to achieve good results in order to reduce any mishaps, any torsional stress on the instruments that we're using, and to understand more and better the root canal anatomy. I've noticed I'm a part-time lecturer or clinical supervisor at the University of Jordan here in Jordan. So I've noticed one thing first, that most of our students, or some of them actually, use 31 files to negotiate canals, especially in molars. My tip and recommendation would be that try to always use files number 10, 21 millimeter length to secure your glide path, to secure your canal. As you all know, the average length of the root canal in molars, it's around 21, 22 millimeters. So basically, most of the cases, 21 will be enough. Sometimes if you need 25, that would be fine if you have a long root. Rarely you will need more than that in molars, in posterior molars. So in order to have a better tactile sensation, in order to have the files bend less, in order to reduce the potential of file separation, and you will have more stiffness, so always use files number 10, not 8, because they will bend quickly, they will be distorted. And 15 is much more larger than the 10. It's 50% larger, and it's not recommended to be used to secure your glide path. Basically, it might create ledges if you have any internal curvatures in the canals. So file 10 would be your sword weapon to open up and secure your canals. First of all, as you all know, a glide path involves after finding the orifice, and then we follow the canal with files number 10. We can use lubricants if you want. it's recommended that we pre-curve the tips even for straight canal. Pre-curving the tip might help a lot in like following up the any root canal anatomy, any curvatures. The tip that I want here to talk about as well is that after I completely finish and shape the canal, I use file number 10, I pre-curve it, and I slide it along the walls of the canal. Sometimes we find lateral canals that way. Sometimes we find like any deltas or ramifications inside the canals. So this is recommended as well. And always never push hard on your files because you will distort the files and you might fracture them as well. So after we enter the canal and we try to achieve the full glide path, then we get to take the working length. I will talk later about the working length and what's the best way to get a good working length. And afterwards, we need to achieve patency. Patency is very important in my point of view, and I do that between every file and the other. I irrigate it, I get patency to make sure that no debris are collecting at the tip of the root. And from my supervision in the dental school over students, I see a lot of cases where they start very perfectly and then they end up asking me that the canals are blocked by the end. Usually they get blocked by the debris because number one, maybe not enough irrigation solutions are used, or we're not achieving patency between each file and the next one. Patency, basically, we can use file 10 or file 8 to go beyond the apical constriction with like 1 millimeter. It's beyond our working length by 1 millimeter. That would be enough to achieve patency. So after we do that, we verify our glide path. And this is how basically we place the file. Oh, sorry, that should have been a video. Anyhow, these are a couple of cases where we have slight curvatures, where we have a retreatment over here with a severely curved root, ledge, perforated tooth, and we could achieve very nice results with after establishing the proper glide path. And even as I mentioned before, even lateral canals can be negotiated sometimes with files. I have many cases where actually I couldn't negotiate the lateral canal with a small file 8 and 10. So it's a good way to pre-curve the file and slide it along the walls after you finish. The next thing we're going to talk about are the confluent canals. The confluent canals, as you all know, are where canals merge at some point and they meet. So we call it a confluent canal. Basically, this merge can be like very smoothly, and sometimes it can be abrupt and cause some problems, which we will talk about now. As you all know, the classifications for the canals like Wayne or the Bertucci classification, they show that type 2 basically and type 3 they have confluence at some point. One more thing is that these confluent canals can be like, as you all know, more present in the lower mandibular mesial molars, like the mesiobuccal and the mesolingual canals, and sometimes there's a middle mesial canal over there. In upper first molars, the upper 6, usually the mesiobuccal and mesiobuccal 2, they have more than 50% chance to be like confluent as well. Premolars, upper 4s, lower anteriors, they all have a big chance of having confluent canals. The problem is with confluent canals, if you don't know beforehand about them, you might end up fracturing a file at the merge. So this is basically why you should know about it before you start cleaning and shaping. This is the main reason. One more thing is that to avoid zipping, over enlarging of the apex, and over preparation of the canal itself. Because if one canal is reaching the apex, then you don't need to reach the apex with the other canal as well. And usually we go for the more straight canal. As example, in this tooth that you can see here, it's a clear mandibular molar, which has two mesial canals joining. One of them is the mesiolingual, which is more straight, and the mesiobuccal that you can see it here marked. It has multiple curvatures in it. So usually in the lower molars, we go for the straight mesiolingual canal and prepare it to its end. And afterwards, we can prepare the mesiobuccal only until the confluence happen. And how do we know where is the confluence? There is more than one way. One of the ways is to place a file in the first canal, and then place another file in the other canal to make sure that about the point that they join. We can use the apex locator as well to check on that the other canal, we've reached the full working length with this way. One more way to know is by using the gutta percha. We usually can prepare the more straight canal, which is in lower molars, as example, the mesiolingual canal. And then we place a file in the mesiobuccal one, as you can see in this video. We just place the file and then we take it out, and then we pull the gutta percha out. We can see a notch at the tip of the gutta percha, and that's where the canals are merging, and that's where we should stop our preparation and obturation for the mesiobuccal one. And with my little experience, I believe that most of the separation of instruments in the lower molars, it happens at the mesiobuccal canals, and one of the main reasons is this confluence. Another way to know where the confluence is during the irrigation. As you can see in this video, when we're irrigating, this is an upper molar. I do suck from one canal, from the MB2, and you can see that the solution is being sucked from the other one as well. So that means that they are meeting at some point. So usually the obturation would be the easier part, because the gutta percha we usually obturate the straight canal, and then we go for the other canal and obturate it just until the confluence. Our next tip is to see how we can find the calcified and missed canals. Most of the retreatments that we've got in our clinics, more than 42%, according to studies, are due to missed canals. And it's the main reason why we do retreatments. One of the reasons why we miss canals during the treatment is because we're not taking more than one angled X-ray. As you can see here, when we take another angle for the X-ray, we can see that there is another canal. I don't know if you can see my mouse or not. Okay. All right, I'm not sure about that. However, on the lower right side, you can see that there is a panoramic view. And please, dearest all students and my colleagues, please don't ever rely on a panoramic X-ray for root canal treatment. We only take periapical X-rays at least, if not a cone beam one, for root canal treatments. So we take a periapical, angled periapical, to make sure about the configuration of the roots, and then hopefully we won't miss a canal. Another case of an upper 7, where the previous dentist cleaned and filled 3 canals as he expected that it would be, and then the patient came complaining of periapical lesion and pain over that area. And by taking an angled one, it can show that there's a completely missed root, and there was more than actually 4 canals. There were like 5 canals in this tooth. This is a case I've seen yesterday, a retreatment case that was referred to me for the retreatment of upper 7. I thought it's like a straightforward case. When I took an angled X-ray, as you can see, I realized that there's a separated instrument hidden in there. The other tip to find missed and calcified canals, and even to see better what you're doing, is always to use a front surface magnifying mirror. It's a cheap mirror, but usually, I don't know why not everyone sell it and have it, but here in Jordan, we usually have it now at every dental store. Basically, you can it shows better because there's no reflection for what we are seeing. And usually when we're dealing with root canals, then we are having indirect vision through the mirror, either if it's an upper tooth or a lower tooth, because we usually are looking inside deep at the canals. So how to know if your mirror have a front surface or not? Just place any object, any pen, file, anything. If you can see any space between the object and the shadow of it, then this is not a front surface mirror. This is it has a shadow. Yeah, the front surface mirror is that, like you can see on the right side, the object that you've placed should be exactly pinpointing at the shadow of it, at the reflections. Try to use magnification. Microscopes definitely are now they're the standard for endodontics generally, and endodontists usually use microscopes, but at least every general dentist can use magnification with loops, and with the headlights. They're very useful. The other thing is that we should know more about the anatomy of the teeth, and we've already learning that in the universities. Basically, we all know now that mesobuccal 2 canals are found in more than 95% in upper molars, according to the studies. They're found less a bit in second upper molars. Lingual canals are found in 45 lower anterior teeth, and middle mesial canals are found almost in 46% in lower first molars. And some premolars, they have like 3 canals. We have C-shaped molars. So basically, if we know that the upper 6, it has 4 canals, then we should be looking for the 4th canal, and we're not gonna miss it. If we know that the lower anterior, and we believe that it has 2 canals, we should be looking for the 2nd canal. If we tried our best and we couldn't find it, then okay, we can assume that it's not there if we don't have like a CBCT or something. But please, if you're doing like a treatment for an upper 6, always check very carefully for the MB2 canal. The dentine map will show us sometimes a bit about the information about the canals. So we always advise not to ruin the floor of the pulp chamber by the burrs. Always after you get access to the pulp chamber, try to use like the endo Z burrs or the safe burrs for completing the unroofing of the pulp chamber. These are all cases that like look nice for like an upper first molars. They all unfortunately failed because of a missed mesobuccal 2. You wouldn't wish for yourself or for your like parents or someone that you love to have a tooth crowned, maybe part of a bridge that has a root canal treatment, and then he should like remove everything and do a new restorations and redo the root canal treatment because we have missed a 2nd mesobuccal canal. Always look for it because it's mostly it's gonna be there. And trust me, you don't need a microscope to find the mesobuccal 2. You don't need magnification to find it. You just need to believe that it's there, number 1. And second thing is you need to check and to know where it is. As we said and mentioned earlier, that the untreated mesobuccal 2 canal is mainly the main reason for failure in maxillary upper molars. And trust me, I see this mostly on daily basis. Good treated root upper first molar that has failed because of an MB2. It has some sort of lesion, some sort of discomfort by the patient. It was treated like some time before. It always come back with failure if we haven't opened the MB2, unless we are very lucky and have a confluent canal with a mesobuccal one, and we've treated well the mesobuccal one and sealed well the pulp chamber, then maybe we won't have like trouble coming out from this tooth. But how can we know? How can we guarantee that this mesobuccal 2 canal is not separate canal, as we could see here in these cases? Most of these cases fail because the mesobuccal 2 is separate. And it's like we are missing a complete root. It's not missing just a canal. And some people like it's just an MB2. We couldn't guarantee ever that it's not a separate canal we're dealing with. It's like just we're leaving a full root. So we said that it's usually present more than 90% of the cases. And sometimes it doesn't fail because it has like confluence with the other canal. And studies have found that you can find it in more than 75% without a microscope. And trust me, if you train yourself well where to find it and how to find it, I believe that this percentage would be much higher. So first of all, the MB2 usually is covered by a layer of dentine shelf, and that's one of the main reasons that we usually can't find it. How do we get rid of this dentine shelf? We mainly can do that with ultrasonics. This is number one. Number two, we can use the long neck round burrs, slow speed in a very careful way, just to remove this dentine ledge and try not to, we're not gonna go deeper than 1 millimeter, maximum 2 millimeters inside. So you wouldn't like be afraid of any perforation that may be caused or anything. So after you remove the dentine shelf, you might see like a blood spot. If you're dealing with a vital tooth, you might find like a white small shadow if you're dealing like with a necrotic tooth or a retreatment case. So usually this is how we remove the dentine shelf. And then mainly, maybe many of you have tried to negotiate or found like a mesobuccal 2 canal, and then when they enter the file goes like 1-2 millimeters inside, and then they couldn't get past that and get like a glide path inside the canal. Usually that happened because of the dentine shelf that we're talking about. And one of the tips to try to negotiate these canals is to go distally, use your files more distally in order to be able to negotiate the mesobuccal 2 canal. Every dentist or endodontist use a different way to negotiate it. Some people negotiate it with hand files. Others, they negotiate it with reciprocating files, rotary files. I do not recommend that you use any rotary file before you establish a good glide path because it may cause file separation, especially in the MB2. So this is a case, an upper 6 and an upper 7. The patient came complaining of discomfort coming out from the upper 6, which was treated some time before. The treatment mainly looks good. So first thing I do is that I ask for a CBCT. As you can see here, we can see that the mesiobuccal root in both 6 and the 7, the first and the second molars, They are oval in shape. We can see on the axial view that there is another canal over there. And sometimes we don't see the canal. We see that the guttapercha is not centered. And by that, we can know that there is another canal in that root. Okay. All right. So we opened up the pulp chamber, and I start with the long neck burr, roughening around, removing the old composite and removing some sort of calcification around that area, as you can see it. I usually ask my assistant to blow some air while I work dry, because you can't work with water in such conditions, because you wouldn't be seeing anymore anything what you're doing. We use the long neck burrs in order to be able to see where we are actually drilling. And afterwards, I irrigated. Again, trying to trough where I could usually see the mesobuccal too. Usually, it's between the mesobuccal and the palatal canal, more towards the mesial. This is where usually it is, but in this case, it was more towards the palatal. And that happens. You can see here that while I'm troughing, a white dot showed up. Got my hand file. You can see it very clearly over there. And then we can see with the hand file that we could negotiate the mesobuccal 2 canal. Here is the confit radiographs showing that we have separated ones, and even in the first molar now you'll see on the post-op that they're not confluent. They look confluent on the confit X-ray over here, but this is the obturation, and you can see clearly that even the first upper molar has separate canals, and that was mainly the main reason for the lesion and the discomfort that he was feeling. Sometimes don't be panicked if you found a third canal. Some mesial roots have like 3 mesobuccal canals. It's not you should like look all around that area where you could see the mesobuccal and the mesobuccal 2 canal. Maybe you'll be lucky or not lucky to find a mesobuccal 3. I prefer not preparing them to large sizes. 25, 20, 30 or 4 would be more than enough. So the next thing we're going to talk about the working length determination. Basically, as you all know, we have the anatomic, radiographic apex, and the diameters of. You all studied about all the anatomy of the apex and the apical constriction. We usually have seen for a long time. We rely on radiographs for working length. Now we're going to talk why we are not doing that anymore. We usually rely on more than one thing. The first thing is that we need to understand that the apex usually, or the apical constriction, it does not coincide with the radiographic apex. All right. Sometimes we have like some sort of resorption over the apex. Sometimes, as in these cases, if we followed the radiographic apex, then we are over obturating, over instrumenting, and this may cause a problem for this tooth and for the patient. So mainly we depend on electronic apex locators, and we then confirm with a radiographic apex. First of all, my recommendation for that is to get a preoperative X-ray for sure, and try to measure the estimated working length over there. Like in here, we have angled X-ray that showed us another instrument. I think, yes, this is a video where we could how to measure the estimated working length on the radiograph if it was digital, and even if it was like on a film, you can measure it with a ruler. And this will give me an estimate of how long should this root be. So as example, if I measured it as like 20 millimeters, and then the apex locator is giving me a reading over like 14 millimeters, I know that there's something wrong. I'm not around the proper length. And if I measured it again, like around 20 millimeters, and I reached like 24, 23 millimeters, and the apex locator is not giving me any reading, then there may be a false negative reading as well. As you all know, might have false positive readings when we have like contamination with the saliva, with a amalgam filling, or if there was a crown, a perforation. There are multiple reasons for the false positive ones, and as well for the false negatives. So basically, it's very important to get a pre-estimated working length before we do. And usually, I ask my students if they've got that, because it's important to when you take a estimated working length, that it's close to what we are expecting. Afterwards, we use the apex locator. The only proper reading for the apex locator is the zero reading. I'm not saying that you should end at zero. What I'm saying here is that when you reach zero, then you've reached the apex. And usually I go bypass the zero, like -1 with a small hand file, to make sure that it is actually the apical constriction, and then I go back. Now, get the zero reading, write it down, and then you can deduct whatever you want. You want to work 0.5 millimeter from the apex, you can. You want to work 1 millimeter, it's debatable. We're not going to discuss this now. But however, the only true reading is the zero reading. So as example, if the apex locator, you went down from 1 to 0.5, that shouldn't mean that you are 0.5 from the apex. This 0.5 may stay for like another 2-3 millimeters until you reach the apex. So the only proper reading is the zero reading. And then afterwards, we take a radiographic to confirm that we are around the length. And even on the radiograph, if you were like 1-2 millimeters short, 3 millimeters short, but the apex locator is giving you that reading, rely on the apex locator reading, because as we've seen before, that we have some cases where the radiographic apex does not coincide with the apical constriction. If you're accessing the tooth through a crown, some tips that you can do, like if you have to go through a crown, an old crown or a new crown, a metallic crown, you can cover the shaft of the file with plastic from any like calcium hydroxide applicating tip, or you can cover it with Teflon. I don't know if probably it has different names in different countries. However, you can cover up the part that will be in contact with the metal and isolate it, so you can use the apex locator reading properly. Okay. Okay, sorry, I think in here. Okay, we've talked about this, I think, and we have here some. Okay. Sorry, I think there is here a small problem with the slides. Okay. Usually our procedures are long. So what we recommend is that we use the bite blocks or mouth openers, mouth blocks, whatever you name them. The patient usually gets relieved to be using it, so he wouldn't like have to open his mouth wide. And plus, you will have more space and more room to work, especially when you're doing root canal treatment and you need like a good space. Rubber dam is mandatory, it's out of question for sure. And we usually, after placing the rubber dam, unfortunately, I've seen that many dentists like hate rubber dam and do not use it after they get like out of college. And I don't know why that is happening, but maybe because it wasn't like used properly even during the good days at college. Usually, if we need to do like a pre-endodontic build-up, then we have to do that to get a good grip, and we can use like the liquid dam as well to isolate around the tooth. Because I've seen students like where they are placing rubber dams, but unfortunately we have a lot of saliva coming out from the tooth, especially if it was like a lower tooth, or the calcium or the sodium hypochlorite is all over the patient's mouth, and this is definitely will cause a weak link in the endodontic chain. The endodontics generally and root canal treatment is like a chain, and each link is very important, and the strength of the chain is by the strength of the weakest link. So try not to cause any weak link during your treatment. If you're doing root canal treatment for like a premolar that you have filled recently, or it has like crown or something, and always to avoid placing the rubber dam on the wrong tooth and treating the wrong tooth, you can do two things. The first thing is that you can like start drilling before you apply the rubber dam and then apply it for the tooth that you have drilled. Or you can place like count the teeth through the hole and then place the rubber dam as we're gonna do here. Yes, it happened with many dentists. It happened with me once that I opened the wrong tooth because both teeth were sound. I applied the rubber dam on the wrong tooth, and I was very lucky because it was like a previously treated, both were needed root canal retreatment. So I was lucky that I didn't cause any damage for the tooth, but you might open a sound tooth by doing that. So here, basically, I've seen this patient yesterday. I recorded this quick video to show you. Basically, you can see through the clamp that we can see the canine, and then we go back to the first premolar, and I need the second premolar. So this is how I make sure that I place the rubber dam around the second premolar. Always don't forget to release the rubber dam from the wedges. And I usually use the liquid dam to avoid any leakage from around the rubber dam both ways. So the patient won't feel any sodium hypochlorite coming down his mouth, and plus we're not going to have any saliva or anything coming in contact with our tooth. Sorry if this took too long. Basically, as I mentioned before, do not cause a weak link in the strong chain of endodontics. And thank you for listening, and thank you for being here. And sorry again if we were a little bit late for this evening.
Thank you so much, Dr. Hasan, for this amazing presentation. And all of these steps are very much needed for all dental students and even fresh graduates like me. I want to ask everyone, if anyone has any questions, to write them in the comment section or raise your hand so that Dr. Hasan could answer. Until then, I have a question of my own. What do you think is the latest advancement in endodontics that every dental student should know of?
Well, the latest advances in endodontics, generally speaking, we are talking about bioceramics mainly. Now we're heading toward like AI and AR models in endodontics, which are much more advanced. But as we speak about the most advances now are the motors, basically the ATR motors, and the motors that like work in both rotation and reciprocation motion when they found any obstacle. They are mainly useful. Bioceramics, I have my own like I use them definitely for some cases, but not for every case, and I do not recommend that we use them for every case for now. It's still early, and we will like find it really hard to have to retreat these cases if they fail for a reason or another afterwards. If everyone started to use bioceramic sealers, and we know that not everyone are doing good root canal treatments, so we will have a lot of future retreatments with bioceramic sealers that are very difficult to retrieve.
Okay, thank you. We have a question from Ahmed. He's asking, what is the most efficient way to negotiate MB2 canal in your opinion?
As I mentioned during my presentation, thank you, Ahmed, for the great question. As I mentioned that basically I use hand files after I remove the dentine shelf. If I couldn't get my hand file past the last the first 2 millimeters, then I use the long neck burrs to remove all the ultrasonics, to remove a little bit more of the dentine toward the mesial part of the tooth. Usually the canal start like in an angled way and then it goes straight. So this, I need to remove this dentine shelf and this angle, and then afterwards I can like negotiate it. Hand files definitely they're in my opinion they work best to negotiate mesiobuccal 2, mainly files 8 and 10. 6 might be very small for that. 15 will definitely cause ledges and problems inside there. So basically file 10 as we mentioned.
Do we have any more questions before we conclude? Everyone? Okay. I think Epic is asking, firstly, thank you for the excellent lecture. I was wondering about the benefitful materials and gadgets for students whom will just start practicing endodontics this year in clinic. I need your opinion. You've mentioned a bit about loops. For example, what are the most useful properties for loops for starters would be?
All right, that's a great question. Actually, I tried to, in this presentation, not to mention the more advanced tools and things, because we know that we're dealing here with students and fresh graduates. So basically, the mouth probe is important. An apex locator, if it's not provided by the university, it's a good thing to have. Rotary files, if you're allowed to use them, that would be useful after you get well trained with the hand files. If we're talking about the first year, like in treating patients, definitely we're going for the hand files over there. As for the gadgets, the loops, yes, I do recommend that we start using the loops. Don't start like in endodontics directly. You can start like doing like some sort of scaling and polishing first with the loops to get comfort with them, and then with the fillings, and then you can get like higher magnifications for doing like and seeing inside the root canals. Basically, we usually start at 3.5 x magnification, although that I've seen that many dentists started at like 5 and 6 x magnifications. They struggled a bit at the beginning, but they were happy afterwards. But as a student, I believe that you should start with a low magnification around 2.53. That would be useful for you. And the front surface mirror, trust me, guys, believe me that it makes a big difference. I don't know if you used it, Tasneem, or not, but sometimes even in the college, I've got like some disposable or sterile ones in my pockets, and I give them around for students so they can see what. Honestly, if I use the mirror that the student is using to help him out with the treatment, I look with the mirror and I don't know how you're work. I can't see anything. I really can't see. There's a huge shadow over there, and I don't know. So
that's preparations happen at dental school. Yes. Lots of errors.
Yes. Sometimes small things, very small tips and small things would make a difference, a big difference. Yeah. So the front surface mirrors are definitely should be used.
I don't remember if we had them. I was at the Jordan University of Science and Technology. But even the mirrors themselves, whether front surface or not, they were really damaged. So it doesn't matter either way. I'm not seeing anything.
The mirror costs less than $1. It's around $1, couple of dollars maximum for a really good one. So my advice for you to learn more, to see more, just get your own if they're really scratched and damaged and they're not providing good fronts. And I'm talking about the front surface mirrors. The regular mirrors are much cheaper even than that. So it's really worth it to invest in seeing what you're doing.
Yeah, the tools you use are the most important. We have a couple of more questions. Someone is asking, do you recommend hand files or files like Wave 1 when working with curved canals? If the hand files are recommended, how high can we get to be sure that it's cleared?
All right. Usually the main player in the curved canals and when we like bypassing a ledge or we have an obstacle are the hand files. And my main file that I feel comfortable afterwards is file 10. When we secure the glide path, which means we've got a loose file 10. Loose file 10, which means that if I place the file 10 in the orifice, I can like push it just with my finger like this. I'm not watch winding. I can push it like this until it reaches the working length. So this is how I secure the curved canal with file number 10 at least. Going larger with hand files in curved canals are a little bit tricky because if you're not using nickel titanium hand files and you're using the regular K files, you might cause ledges and problems inside the curved canal. So we usually go for nickel titanium files after file 10, either hand or rotary wave 1 reciprocating files, whatever you want, with a night tie that has like a good shape memory and good flexibility.
Okay, thank you for your answer. Another question, which ultrasonic do you recommend with irrigation?
I'm not sure if the question means the activation for the irrigation solution. Usually I do ultrasonic activation. I've got the IRRISAFE tips from Action, and I've got from 8 Teeth the portable Ultra X, I think it's called. It's really useful. It has like small tips that are long-lasting tips for activation of the irrigation. And you can use either the sonic ones, which are like plastic or I don't know what they're made of, but they're much cheaper than the ultrasonic ones.
Okay, we have another question from Ahmed. Thank you again, doctor. During obturation, do you recommend obturating one canal and cut excess, then the other, or all canals at once, then excess gutta-perca removal?
Okay, let's talk about mainly the mostly used obturation techniques. If I'm doing lateral compaction, I would do one canal at a time, but I would seal the other canals with if I'm not seeing them properly, then I need to seal them with like a cotton pellet or something to try to avoid placing gutta-perca accidentally inside that the other canals. I've seen students where they like when they're obturating the mesolingual canals, they accidentally place an accessory cone in the mesobuccal canal, and then they get lost in between what to do and which to pull and where to go from there. If you're using the more advanced obturation techniques like the continuous wave of continuous waves for obturation, we usually place one or two gutta-perchas, we cut them, and then we can go apically with the pluggers, with the heat pluggers. So basically one canal at a time, not everything. And what this is also helps with seeing, because if you have a molar with multiple canals, then when you place all the gutta-percha, you're not going to see anymore. So just go for one canal at a time.
Yes, I totally agree from experience. I think we have one last question. Do you recommend using hand files to activate the irrigation solution if I don't have a specified ultrasonic for activation?
No, not hand files. If you don't have a device for activation, you can use the gutta-percha, the main cone for gutta-percha, by pumping in and out. This way, you will get rid of the vapor lock, and you will activate slightly the irrigation solution, but not hand files for sure. They're not going to do much in the canals. And plus, I assume that when you want to activate the canals, the irrigating solution, that you have used like a remover for smear layer, like EDTA or something. So afterwards, it's not recommended to use hand files, which may cause the smear layer to form again.
Okay. We have a question from Maria Hazayadian. She's saying, thank you, doctor, for this amazing lecture. What is your irrigation protocol?
All right. First, my greetings to Marah. She's a dear student and friend and colleague and everything. My irrigation protocol mainly, I use sodium hypochlorite all the time. I irrigate between each file and the other one. When I reach the end, I use EDTA solution to remove the smear layer, and then I use the sodium hypochlorite to remove any remnants of after removing the smear layer, and then I dry. Some dentists use like saline afterwards. I don't. I just don't. There's no enough. Yeah, it's debatable even in the scientific articles whether to use it or not. However, this is my irrigation protocol, Marah.
I've also once heard that some dentists they disinfect the gutta-percha, the master cone, before they put it. Is that recommended?
I do that actually. I have like a small a compartment where I place the gutta-percha before I take the confit, and after I take the confit, I place them there, and then the assistants, it's full concentration sodium hypochlorite. We leave them there for a couple of minutes, and then we put them in alcohol for a few seconds, and then we dry them. So this way we will assure that the gutta-percha that we're using is disinfected.
Nice. Okay, another question. What's the best intracanal medication usually used, and mixed material accepted or avoid?
I honestly, I'm gonna say what I do. I don't know. There are plenty of materials over there. If I want to use an intracanal medicament, I just use the calcium hydroxide, not mixed with anything, not with iodine, not with anything, just a regular calcium hydroxide, and that's it. I just use it when I have to.
So, would you suggest that some dentists can leave the canal without an intracanal medicament between visits? Is that okay?
I do not recommend that. My personal opinion in that, I do not. All right. Some dentists or endodontists are raising up this subject, and they're like mentioning that it's hard to remove the calcium hydroxide afterwards. Well, in my experience, the water-based calcium hydroxide are easily removed, and even in the second visit, when we're removing it, it's not just like we're doing it for a couple of seconds and then we're obturating. No, we need to clean the canal well, irrigate it again, activate the irrigation again. As I mentioned during the lecture, I use files 10 to scratch all over the walls to make sure that we have no lateral canal, nothing. So this usually removes any remnants of the calcium hydroxide. And leaving the canal without a medicament, I've seen some of the cases that I've tried leaving them without. I feel that they might get reinfected, because if it was like we usually do more than one session in cases that are really very badly necrotic, infected, and so on. So leaving the canals may reactivate the bacteria to cause more biofilms and so on. I don't know. So I do not recommend leaving it. But however, I've seen some practices where they inject the calcium hydroxide outside the apex if they got a lesion or so on. This is not recommended and not needed at all, even if it resolves.
Do you think it can be a cause for pain if we do leave the canals open, or it's not related?
Sorry, again?
Do you think if we leave the canal open between visits without an intracanal medicament, it can increase the inter-visit pain?
I don't think it makes a difference. If some people like we are just to make it clear to everyone, we are talking about leaving the canal empty, not leaving the tooth open, so they wouldn't get confused. Okay, so we're sealing the tooth, we're leaving the canal open. Your question was sorry, what was it again? If it gets reinfected?
If we don't put an intracanal medicament, is it going to be more painful?
Regarding the pain, I don't think that there may be any difference in the pain. And some dentists believes that leaving the canal empty would have more gases, and if we have any pus or liquids that it may enter the canal and relieve the apical pressure. But the canal is really very, very, very small. So even if you left it empty, it's not much space to cause this relief, I believe.
Yes, that's true. Just for everyone to know, never leave a tooth open in between visits. That's a huge no. We were talking about obturation. If no one else has any question, I think we can conclude. Thank you so much,
Thank you
Dr.
very much, Christine, for you and for your time, and for everyone in JADS and in IADS. And thank you for having me. It was my pleasure, and I hope that any of you, some of you, got a few good tips for this evening, and hopefully we will meet up again soon.
Yes, definitely. There was no better way to end this Middle East webinar series.
Oh, that was the last lecture.
Yeah,
oh,
it is.
That's great. Oh, thank you.
Much. It's always a pleasure having you. It's a very amazing lecture, and as I said, very concise, straight to the point, very much needed for dental students. Thank you again. It was amazing having you with us.
Thank you, Tasneem. Thanks for everyone, and have a great day.
Have a great day, everyone.